Good morning. It's great to see all of you again, many of you again from the last 3 meetings, and I had the pleasure to actually attend all of them. So I hope that you'll find this informative. I've chosen to update some of the studies you've seen many times before that were presented at San Antonio this past month in December, and also just to do some overview in general about chemotherapy. As you know, many of you have been doing this a long time. It's really been exciting for us who treat breast cancer patients. And I've been doing it about 25 years now. And when I started, we just basically had adriamycin and CMF. And as you can see on this ladder, and you know from your own practice, we've gone from no chemotherapy and lots of patients having recurrences to using the CMF, having a benefit of about 4%, and then the 80s, the anthracyclines, a benefit of another 4%. Then the exciting era of the taxanes in 2000 with about a 5% improvement. And then finally, most recently, the most recent breakthrough was using trastuzumab or Herceptin with probably the biggest benefit we've seen overall. So over the last 20 to 30 years, we've seen about a 15 to 20% improvement in outcome in our patients with early breast cancer. And that's very satisfying, I know, to many of us, but we do have some ways to go. And as Wolfgang mentioned, we've been using a lot of old tools in the past, and we're going to talk about that more today. But the really important thing is we're looking at our newer trials and incorporating some of the molecular markers and the biology much more than we have ever done so before. So chemotherapy continues to improve outcomes and does still, and I think always will, play a leading role in treatment because obviously breast cancer is very sensitive to chemotherapy. Now I wanted to start just by showing you the latest taxane meta-analysis. This was for docetaxel presented at San Antonio. Now there have been several meta-analyses, as you know, looking at taxanes versus not, paclitaxel, docetaxel, and all have shown a benefit overall. And this is the latest one with over 20,000 patients and follow-up for the most part for 5 years. It's with or without docetaxel. And as you can see here, looking at disease-free and overall survival, in the bottom part overall, there was clearly a benefit when you added docetaxel to these regimens. And it was very clear in patients with node-positive disease, much less so in node-negative in this meta-analysis. And if you looked at it even more closely by subgroups, those patients that were younger, that were older, that had hormone receptor negative or positive disease, HER2 receptor negative or positive, all benefited when you added a taxane. The only group that really didn't seem to clearly from this meta-analysis was the node negative, but it was only 4,000 patients, and it may be because there were not enough events, because we've seen taxanes do benefit even in node-negative disease and some of the other meta-analyses. I wanted to mention the PAXO-1 study because I know many of you use the AC followed by docetaxel regimen, and this was just updated at San Antonio last month for 8-year follow-up, and it's the 6 effect versus 3 effect followed by docetaxel. And the 8-year follow-up is shown here, which was still very significant with about a 4% absolute benefit in disease-free survival, and also a benefit in overall survival. It's about a 5% benefit. So this, I think, is very satisfying to see this, that the data still held up after it's been published 3 years ago and presented again. Now, has the maximum potential of chemotherapy been reached? I think that's a big question that we all ask, and I think probably so, but I'm going to go through some of the studies that have shown incremental benefits in our current trials, looking at some questions such as concurrent treatment versus sequential, longer treatments, the number of cycles of treatment, and which agent should be used. Now, if you look at the update from that actually Wolfgang and I gave last year, not this past year, but a year ago at San Antonio, looking at BCIRG 005, which is 4 of AC followed by 4 of docetaxel versus TAC. And then my study, the NSABP B30, which was, again, 4 AC followed by docetaxel 4 versus the 4 of AT or 4 of TAC. We actually presented these back to back. And the BCIRG 005 showed absolutely no difference at all. And the B30 showed a benefit with the AC followed by docetaxel compared to the other 2 arms. And that was disease-free survival, and the same is true for overall survival. And though it's not shown here with B30, I also showed that those patients who achieved amenorrhea, and we had 2,500 premenopausal women, those patients who achieved amenorrhea actually had a better survival than those who did not, which I think is a very important finding in the study. For years, I think the rest of the world, Europe, has paid more attention to hormonal treatment, including ovarian ablation, whereas in the U.S. we have not done, I think, our job in that area. And this study clearly shows that amenorrhea is associated with an improved outcome. Now, the safety are shown here for the 2 studies, and just to mention that Dr. Eierman submitted his study to JCO and mine to New England Journal, so hopefully you'll be seeing them published soon. The febrile neutropenia rate with 6 of TAC without growth factors was about 18%, so it was higher than the 4 AC followed by 4 docetaxel. And in the B30, we had a 22% rate, so it was higher with the 4 of the Taxotere and the 4 of TAC, 16%, and that is with growth factor. So you still do get a substantial number of patients that have febrile neutropenia, even when you're using growth factors. Some of the other interesting findings are the low incidence of heart failure. It's less than 1% in both of the studies. And then most of the patients actually were able to complete the cycles, even those who got the 4 of the 100 per meter squared of Taxotere, as shown on the bottom. On the left side, 91%, and then in the B30, it was 86%. So that's a pretty substantial number of patients that were able to complete that treatment. And this is just to summarize the issue of the number of cycles, and I know it's a question we're going to talk about in my group when we talk about some of the cases, is how many cycles to give. When you look at the BCIRG 005, you had 6 of TAC, 001, which compared the FAC to the TAC. You also had 6, and that was beneficial, as you know, over FAC. And then in my study, the TAC was inferior because it was only 4 cycles. So really the conclusion is you at least need 6 cycles of TAC or chemotherapy for these patients. Now, the big 298 study was also updated at San Antonio this past month, and this is a very complicated study with 4 arms, 2 control arms, A followed by, CMF, or AC followed by CMF, and both of those are 7 cycles of treatment, versus a sequential treatment of adriamycin, Taxotere, CMF, and that's 9 cycles of treatment with 100 of the Taxotere, versus the AT followed by CMF. So very complicated study in node-positive breast cancer, and these are the updated results showing that essentially the AT, the sequential regimen, had the best outcome, but it was not a hugely increased benefit. So really there were little meaningful differences in this study, but the differences may result from combining and sequencing. And as I said, the sequence here is what had the best outcome, though it wasn't highly significant. So how do these results impact the role of chemotherapy and Taxotere in particular? I think that agents do matter. We all know that docetaxel is one of the most active chemotherapy agents, and it's been confirmed by the meta-analysis that I showed you. The delivery matters. We need to at least give 6 cycles of TAC, but I really believe that we've reached the glass ceiling of the maximum potential of chemotherapy in the unselected group. I think we've done enough of these large trials, thousands of women on these trials, and all of us who are in the business of designing trials want to change that and really look at more specific selected group of patients. And I know Martine's going to talk quite a bit about that in her talk. So what is the potential of chemotherapy? What do we know now in selected populations? Because I think we need to really learn from what we have now. If you look at age, for example, and that's been something, it's an interesting phenomena to me that not very many older women actually get put on clinical trials. And to me, it's an age discrimination. I think there's enough data through the years, certainly with the International Breast Cancer Study Group, showing that women who are older who have ER-negative tumors benefit from chemotherapy. We have that data, but for some reason, many physicians are reluctant to put those patients on trial. If you look at the U.S. Oncology trial comparing TC to AC, Dr. Jones presented this last year, I think it was, and it's been published most recently in JCO. And he broke it down into the different ages, as you see on the right. So the younger women, both, and the older women benefited from TC versus AC. So the message here is if you need to give chemotherapy to a patient, the age really should not matter. And following up on that, here is just the forest plot showing that the age over or equal to 65, those patients benefited from the TC chemotherapy. This is a very important trial that was published by Muss and done by the CALGB looking at this question of age. And I always like to use this trial as an example of what we really need to keep in mind when we're treating our patients. And it was evaluated to show non-inferiority of capecitabine to standard chemotherapy regimens with CMF or AC in older women. And as you can see here, it was actually terminated prematurely. And you see on the left side with relapse-free survival that the capecitabine was worse than giving standard chemotherapy. And the same is true, significantly worse for survival. So really the message here from the previous study and this study and other studies that have been published in the past few years is if you need to give chemotherapy to a woman, the age should not matter. If they're fit, they should get what you think is the standard chemotherapy and not less chemotherapy or kinder, gentler, because actually they will more likely have a recurrence. So selected older patients do benefit from the best chemotherapy. Now, if you look at HER2, there are really three key questions at least. There are probably many more, and we could talk all day about it, apply to HER2 positive disease. One is the optimal agent or regimen, whether we should give it concurrently or sequentially, and then the duration of treatment or the number of cycles. And as you're familiar with, there are many trials that have looked at adjuvant Herceptin, and they're all summarized here, the Hera trial being the sequential trial after chemotherapy, the B31 and 9831 with or without the paclitaxel concurrently, or in 9831 having another arm sequentially that I'm going to discuss. The BCIRG using a non-anthracycline regimen with TCH, and then the FINHER using a shorter regimen. So it's really nice that we have so many different trials that have looked at different ways of giving the trastuzumab and give us a lot of nice answers. Now, the BCIRG study was updated by Dennis Slayman at San Antonio, and this is the third analysis of this trial. And as you can see on the left side, the disease-free survival showed that there was a benefit when you compared to no Herceptin, either with TCH or ACTH, but there was an absolute difference of about 3% at 5 years between the TCH and the ACTH, though they are really statistically not supposed to be compared. But if you look at it, it certainly looks like the TCH is not as effective as the ACTH. And the same with survival. It's about a 1% difference between the two. Now, there could be several reasons for that. One, that you do need the anthracycline for sure. Another could be that the carboplatin's not as effective as cisplatin. There's certainly other things that you could suppose on that, but I think it's important to see this data. And when you look at the cardiotoxicity from this study, there were clearly more cardiac events, heart failure events on the ACTH arm, 21, versus the TCH, 4. So that was very significant, with also a significant difference in the decline in ejection fraction from 19% to 9% on the TCH. There were also several leukemias on the two anthracycline-containing arms, and when Dr. Slayman presented it, he presented it as a risk-benefit, saying that overall there probably still could be a benefit from TCH if you take into consideration the heart failure and the leukemia. Now, I think it's important, and since this data's come out, I certainly have discussed with my patients the potential benefit of the ACTH over the TCH and really gone through these risks with the patients before making an absolute recommendation. Now, he also presented the TOPO2A, which you've seen the last couple of analyses that were presented, and it's similar in that those patients who are co-amplified for TOPO2A on the left side, there was no significant difference between the three groups, though the curve of the ACTH is on top. But it seemed to not matter whether you gave Herceptin or not to that group of patients, suggesting that anthracycline may be adequate. I don't know any of us who really feel comfortable with that if we have Herceptin available, but I think for those of you who don't, I think it's an important point. And this is one study, though. We certainly need other data, though it is in about 3,000 patients. And if you look at those that are non-co-amplified, and that means they're only amplified for HER2 but not TOPO2, both of those groups did need to have the Herceptin to show a benefit. The other question is concurrent versus sequential, and I know many of you in the room probably use sequential treatment via the Hera style, and I'm going to show a little bit of update from that from St. Gallen's last year. And then the 9831 was comparing the AC followed by weekly paclitaxel with sequential versus concurrent Herceptin. The Hera study at the 4-year update, as shown on the bottom, was updated by Luca Gianni at St. Gallen's last year, still showing a very significant difference in disease-free survival with the use of sequential Herceptin, with the survival benefit being less at this point at the 4-year follow-up. And the 2-year data has not been presented yet from Hera. An interesting analysis that was done at the time the combined analysis, the combined data was presented, many of the patients actually crossed over to get Herceptin on the Hera trial. And the analysis that was presented was looking at those patients who crossed over versus not. And this could have been quite a bit after they received their chemotherapy, showing that there's still, in this exploratory analysis, was a benefit for using Herceptin in the crossover period. Now, there are a couple trials out there that one's been completed looking at lapatinib after chemotherapy in those patients who didn't get Herceptin, and that data is the TEACH study. It hasn't been reported yet, will help us determine if there's a benefit there. And then the neratinib study, looking at getting neratinib, which is a tyrosine kinase inhibitor for HER2, after adjuvant Herceptin. So we still have lots of questions we're asking regarding maintenance HER2 targeted therapy. And Dr. Perez presented an update of the concurrent versus sequential for 9831, and comparing the control versus sequential, you can see there was a very large benefit of about 8% for disease-free survival. If you looked at sequential versus concurrent, which is the data we'd all been waiting to see, there was a difference of about 3% or so, which was, there's a lot of statistical information about this, basically about a 25% reduction in recurrence, and felt to be somewhat significant, but it has a lot of statistical information behind that. But certainly when you look at the curves, it looks like the concurrent was more effective than the sequential. But I think we still have a lot of information out there. We have the Hera 2-year data that we need to see before an absolute conclusion's made. But I would say that my feeling is because of the synergy with chemotherapy, I would prefer, certainly, and most of us in the U.S., to use concurrent Herceptin therapy. And what about the duration of treatment? The FINHER study looked at docetaxel FEC or vinorelbine FEC, and they did they actually gave the trastuzumab with the taxane first, only for 9 weeks. The Hera, as we talked about, was 1 versus 2 years, and then the 9831 are both of those arms are 1 year of treatment. In the FINHER study, that has been updated and just published by Heikki Joensuu in the Journal of Clinical Oncology, showing that the distant disease-free survival is no longer significant compared to when it was published in the New England Journal of Medicine, and that the overall survival is really not significant either. My caveat to this study is that it was a very small study. It was only 200 and some patients, very underpowered, and certainly most likely there is still a benefit, and it's just too small to really see that. But I just wanted to show this for completeness because it has been published and updated very recently. Now, there are a lot of ongoing trials, fortunately, looking at this question to address adjuvant trastuzumab duration. There's the short hair study looking at 1 year versus 9 weeks, the SOLD study, 1 year versus 9 weeks, and then there are 3 studies looking at 1 year versus 6 months. So with all of these, plus the Hera study, 1 year versus 2 year, we'll have a lot more information in the next 2 or 3 years or 4 years to really help us determine how long we should be giving Herceptin. So to summarize the HER2 positive disease, all 3 questions are very important. The optimal agent, concurrent versus sequential, and duration. With the subgroup definition of HER2, we found many more pronounced differences, and I think that's why all of us were so excited with this data, because the curves actually separated more than we'd ever seen with many of our other clinical trials. Now, what about getting into more of the subtypes, as Dr. Eierman mentioned? There's recent data from the San Antonio meeting, I think, that was very important, and this is unpublished data. It was in a poster that Don Barry presented. If you remember back to years ago in 8541, so that's been over 20 years ago, the study that compared the low-dose adriamycin regimen to the intermediate to what they say was the high dose, but really was standard, that was published by Mus in the New England Journal of Medicine, and really showed that if you gave the low dose, the patients did not do well, really telling us all that we shouldn't dose reduce, we should at least give standard treatment. Well, they actually looked at the HER2 and ER status in this group of patients, and if you look at the upper right-hand corner, those patients that had ER positive, HER2 negative tumors, really it didn't matter if they had low or high CAF. And this is a theme I'm going to talk about in the next few slides. So it really suggests that maybe chemotherapy really wasn't important overall for this group, as does this study suggest that, and this is the 9344, the AC followed by paclitaxel or not. And this was published by Dan Hayes, showing a similar result, that if the patients had HER2 negative ER positive disease, it didn't matter if they got paclitaxel or not. Now, I think taken together, both of these things may suggest it really wasn't the taxane necessarily here or the anthracycline, but it may be that they just don't need chemotherapy to increase their efficacy or the outcome. And the 9344 study was updated at San Antonio and actually was updated at the ASCO Breast Cancer Symposium looking at tissue microarrays and immunohistochemistry. The previous one was taking data from the wherever it had been done. So it was done again, showing that there was no paclitaxel benefit for those patients with HER2-negative, ER-positive disease. This is a major theme that you're going to be seeing, and Dr. Picard is also going to be talking about this too. Now, if you looked at the BCIRG 001 study, the TAC versus FAC study, this was published in JCO last year, looking at the same kind of analyses. And those patients who had that had HER2-negative disease and either Ki-67 low or ER positive in their lower right-hand corner also did not benefit from the addition of docetaxel chemotherapy. And these would be akin to the luminal A-type tumors, whereas those who have the HER2-negative, ER-negative at the top, or HER2-positive, ER-negative, or in the lower left-hand corner, the high Ki-67 or the more highly proliferative lesions, the luminal B-type, all of those groups seem to benefit from the addition of the taxane. That's similar to what I showed you before in the others. So the further definition, according to both HER2 and hormone receptor status, does identify lack of efficacy in a HER2-negative, ER-positive subset with chemotherapy, overall taxane chemotherapy, or even anthracycline chemotherapy. So that just to close with a few other biomarkers, because we're going to see more of this later on. Looking at the PAX-01 study, the one that I showed you at the beginning that was updated, the FEC, followed by 3 docetaxel versus 6 of FEC, when Ki-67 was evaluated, and if you look at the top, it's a kind of a gray line. Those patients had high Ki-67, and they received 3 of the FEC, followed by 3 docetaxel. And the arm A, the bottom, I think it's like an orange or red line, that were ER positive and high Ki-67 that did not receive the docetaxel. There was definitely a difference. So it looked like here, this really is another marker that can help us differentiate the ER-positive patients. These are all ER-positive. And those that had the highly proliferative ER-positive lesions, like the luminal B type, seem to benefit from the addition of the docetaxel. And the other biomarker that's been looked at least 3 studies is tau. In the UK trial, there's no interaction between docetaxel and tau. One study by Tanaka did find that tau levels may predict lack of efficacy in metastatic breast cancer, which has been the leading hypothesis. But when Dr. Pustai looked at NSABP B28, that's with or without paclitaxel, there wasn't an interaction. So I'd really conclude now, and I think most people would, that tau is not really a useful marker to predict resistance from the taxanes. And then in my group, we actually looked at AKT phosphorylation in the B28 study, and we found that those patients that were AKT positive, ER negative, did have a benefit with a taxane. So I'm showing you these just to show you some of the areas which we are trying to look at really to differentiate these groups of patients. So biomarkers are needed to define populations who will benefit the most for a given specific therapy, the right treatment for the right patient at the right time. And this really concerns all therapies, chemotherapy, hormonal therapy, and biologic therapy. So if you look at what I've just showed you, the specific predictive biomarkers, Ki-67 is predictive for docetaxel efficacy in ER-positive disease. Tau is probably not. And then the AKT, the activated AKT, which is downstream to many of these receptors, may predict for taxane sensitivity in ER-negative disease. So to conclude, Chemotherapy clearly remains a critical component of adjuvant breast cancer treatment. I think we'll always be seeing chemotherapy use. We know that breast cancer is very sensitive to chemotherapy, fortunately. The era of one-size-fits-all is over, and we keep telling ourselves that over and over again as we try to design clinical trials and not do these trials without having a clear idea of what we're looking at. The maximum potential of chemotherapy can be reached by targeting specific populations, as is shown with the Herceptin story, and we desperately need biomarkers to optimize chemotherapy to define these selective populations into more clearly tailored treatment. So thank you very much.